Hi, I'm Stephanie Shelton, and this is episode 39 of Conversations on Health, How We Get There. Our neighbor and longtime friend Canada has been the subject of President Trump's ire, and of course his tariffs, since he became president again in January. He's even claimed Canadians would have, quote, much better health coverage if Canada were somehow to become the 51st state. Actually, Canada, like almost all other industrialized countries, has a publicly funded, government-run healthcare system, which is somewhat similar to the UK's venerable NHS, which, of course, this podcast has looked at several times. Every Canadian in the country legally is covered, although some fringe coverage can vary from province to province. Since there's so much inaccurate information about the Canadian system floating around, I thought I'd try to set it all straight in a conversation with the extremely well-qualified Dr. Gregory P. Marchildon. He's Professor Emeritus at the University of Toronto's Institute of Health Policy, Management and Evaluation, and the founding director of the North American Observatory on Health Systems and Policies. Gregory Marchildon has worked as a lawyer, senior public servant, and consultant for numerous governments and international organizations. In recognition of his impact on both scholarship and public policy in Canada, he was made a member of the Order of Canada. I'm embarrassed at how much I didn't know about the Canadian system, even with my research, until I talked to Greg. I think you'll learn a lot also, so let's go at it. Greg, welcome to the podcast, and thank you so much for taking this time on a Saturday afternoon to talk to me.
Oh, happy to join you.
So you are going to talk to us about the Canadian healthcare system. And I think most of us, particularly in the northern half of the United States, have probably been to Canada or know somebody who lives in Canada, or we moved back and forth. Until recently, it's kind of been borderless. It was a place that was an extension of each other for both of our countries. And I know so many towns where the line goes down the middle up in Maine, for example, and nobody knows which country they're living in. So I think most of us think that we know about the Canadian healthcare system. Mostly what we hear about are waiting lines for elective procedures, and people trying to come over the border and see private doctors in the United States, because it's always been portrayed as, well, you don't want that. We have our private system here, and we want it to stay that way. Well, actually, our system, after paying some attention to yours, doesn't seem all that different. In the sense that Medicare and Medicaid and Veterans Health and all of that, a lot of that is very much like your somewhat decentralized yet nationalized system.
I think that the essential problem here is that both Canadians and Americans assume they know quite a bit about the other. And the reality is there are some pretty big differences in some ways, and then there are some striking similarities in other ways. But you really have to know what those similarities are and what those differences are, and to distinguish between the two clearly. The first thing, I'll start with the most elemental aspect of Canada relative to the US, is that Canada is the most decentralized federation in the OECD, and according to some measures, more decentralized than Switzerland. So that provincial governments play a really enormous role in the provision of many public services, as well as the financing of public health care. And of course, with that, the governance of public health care. And I like what Richard Saltman said in an earlier podcast, which is to always be careful to distinguish among the characteristics relating to finance, delivery, and governance. And Canada is like a three-layer cake. And the provinces play a really critical role in this three-layer cake. After I'll talk about the role of the federal government because it's still very strategic. Uh,
Where
but
does it, where does it, first of all, let me just start at the beginning. How long has there actually been something you could call a Canadian healthcare system?
Well, I think since the late 1950s, but there has been what I would call universal health coverage, at least for critical hospital and diagnostic services in the province of Saskatchewan since January of 1947.
Hmm.
It predates the National Health Service by a year and a half, so it can lay claim to being one of the first universal health coverage systems in the world. Um, so this means that the initiative was taken at the provincial level. The federal government came in later and it offered shared cost funding, that is 50 cents on every dollar, to any other province that adopted a program similar to Saskatchewan. And by the end of the 1950s, all of the provinces had programs and were getting then shared cost funding from the federal government. And that's the strategic role of the federal government. And that was the first stage. That was hospital services and diagnostic services. The second stage came in the 1960s, again with the province, and again the province of Saskatchewan taking the lead in introducing universal medical care coverage. That included all physician services. And the federal government then came in the latter part of the 1960s, offering again shared cost money to all of the provinces if they adopted a program that basically adhered to the principles that the Saskatchewan program adhered to. So the design of that was single tier. That is, the government paid all the bills, private insurers were not involved. And the second thing, which is a little more difficult to understand, is that it was single tier. All basically people had access to all facilities. There was no parallel private tier and parallel public tier. It didn't matter the ownership of the hospital, the ownership of the clinic, the way in which doctors worked. Basically, they all came within the rules of Medicare.
And the Medicare name, I wonder if we took ours from you, because Medicare started in the mid to late 60s for us.
Yeah, 1965.
That's weird,
We
that we should have the same, and actually it
Yeah.
works the same, much the same way.
Well, it actually doesn't because Medicare is a social health insurance program in the United States. It's based upon your contributions to Social Security over time, and it's for people 65 and over.
True, but
Whereas the program for Canadians is for all residents, and it's based upon being simply a resident of a province. And then there are federal rules over that to ensure portability, etc.
I think this is the part that's a little difficult to grasp. In almost every other country we've looked at, even Sweden, which has also got provincial control to some extent, area control, but is much more tightly controlled but at the federal government level, I think.
Yes.
But the sense is that the care that you get is the same wherever you go. And my sense from the reading is that you could live in Ontario and get one level of paid for care, and then you could be living in, I don't know, Quebec and get something else, as long as the principles that the federal government dictated are observed.
Well, I would I would actually describe that differently. I would say that 95% of the coverage package is the same across the country. But there is a gray area of 5% where there are differences among provinces. And
And
you're going to get,
what are the different, what kind of things?
well, there was a difference, for example, in terms of abortion services. Some provinces, one province in particular, Prince Edward Island, the smallest province in the country, given its sort of cultural background, etc., just wasn't keen on making access to abortion services part of the system. But over time, they had to give way and allow for that to occur. Even if it was outside the province, that province would have to pay for the service if it was clinically indicated. In other words, medically necessary, and a doctor recommended it. So they had to give way, but there's other services too. For example, in primary care, we get more than simply physician services in primary care. And every province varies a little bit. In some provinces, they make sure that you also get, for example, the services of clinical psychologists within certain primary care clinics. Others do not. There is, for example, post-acute care that involves rehabilitation, sometimes for a couple of weeks, sometimes for 2 months in some provinces. In other provinces, there might not even exist. Those are the gray areas. But that's less than 5% of the system, I can assure you. The other 95% is set. And basically, virtually every diagnostic service you can think of, virtually every hospital service you can think of, and virtually every physician service you can think of is included in that. Another area that is a little bit difficult to deal with is the area of cosmetic surgery, in the sense that you have surgeons in that area that do medically necessary surgeries, but their bulk of the work is what we would call cosmetic. They're both in the system and outside the Medicare system.
When you say cosmetic, I mean, there is no health insurance in our country that I know of, private or public or Obamacare or anything that would pay, say, for a facelift.
No, that's right. And it doesn't in Canada either, but those surgeons also do work that's medically necessary after traffic accidents and
Right.
that sort of
Okay.
thing. People need reconstruction. Of
Right.
course, that's covered under the system, and that would be covered in every province. And so that doctor would have what we call a Medicare billing number, and it would be billed directly to the provincial government in question.
And talking about billing, the thing that is interesting to me, although I guess it's not that different than the UK's system, is that the doctors are private and contract on a per usage, in a sense, per procedure basis with the government. And again, that seems kind of strange in terms of our concept as Americans of systems, but I'm looking back to the Czech system, which I know better than any other, country's system except our own. And their doctors are also little private businesses who contract with the government. So
Yeah,
I
that's
guess
the
it's
bulk
not
of.
so unique.
Yeah, no, in Canada, that's throughout. The NHS is a bit split, right? You have the general practice doctors who are independent contractors, like
Right.
doctors in Canada and other countries. But the doctors that work for hospitals are often salaried. And in Canada, they're not. They work on contract for the most part as well. There are some exceptions. There are times when hospitals will have a radiologist on salary, but that's pretty rare.
Mm.
Generally, they're on contract, and those contracts are negotiated in terms of the rate that they get, which is a fee for service basis largely, but can be per capita capitation type payments or can be a more set payment. That's negotiated between the Provincial Medical Association and the provincial government. Again, the provinces play the critical role in this area and the provincial governments.
Do people ever choose a place to live in Canada based on these differences?
No, well, I shouldn't say absolutely no. There are going to be in that gray area, if one province offers autism services as part of its package, and that would fall into a gray area because there's nothing in the Federal Canada Health Act that says that that's necessarily a medically necessary service. It might be worth it for the family to move if they have a highly autistic child who requires an enormous amount of that kind of treatment. But that would be, those are very exceptional or marginal cases. Most of the time, no. There's very different than the United States. I lived in Washington, D.C. for 5 years, and I know the extent to which, your where you live and the job that you take depends in part upon medical benefits.
Mhm.
And so that's a restriction on mobility to some extent.
Yes.
You don't have that in Canada. So you really, and portability ensures that, your medical benefits are covered whether you're visiting or you're moving to another province or territory.
Losing your job until the Affordable Care Act was passed, which is just not that long ago in our, medical coverage history in
Right.
the United States. People were terrorized by pre-existing conditions. Say you had breast cancer, or you had diabetes, or anything. People would stay in jobs they hated because their medical issues were covered, because an insurance company would be able to turn you down for any pre-existing conditions, no questions asked. And so you could take the dream job of your life, but the medical coverage offered by your company might not cover the issue that is most important to you, which is your health. And luckily, we've gotten rid of that more or less. Although, if you want to change insurance companies in the current time period, which is just beginning now, every fall, brokers will tell you that you are not guaranteed acceptance by a new insurance company, and maybe you better stay where you are. So, although we think we are, the insurance companies have enormous power still over us. And
And
you don't have
Stephanie,
any of
sorry, I just want to say that has enormous economic consequences. The single biggest comparative advantage for the Canadian auto industry versus the US auto industry is the fact that in Canada, they don't need to provide health insurance, the kind of catastrophic health insurance that is provided in the US. And the cost of a car, therefore, making a car is considerably less.
Interesting.
So
Interesting.
that it has enormous consequences outside the healthcare field.
Well, that's a podcast on another subject and for another day, and how fascinating, to look at the economic consequences of all of that. Um, Let me bring it back to the role of the private sector. So we've talked about how doctors are contracted or paid fee for service, province to province. Um, I have been told that, except for the province of Quebec, and that is from a court case specifically, Canadians cannot buy private insurance if they want to. Is that true?
Um, well, let me explain what that means because first I have to, and I don't, the statement without explanation is incorrect,
Mhm.
but it's correct within a context. So let me explain. There are three layers to the Canadian system. The first layer is universal health coverage. And
Right.
that's a narrow band of services, hospital, diagnostic, and physician or medical care services, plus drugs administered within a hospital. Okay? That constitutes close to 50% of all the services offered, but it's less than 50%. The next layer is about 33% or so, and that is a mixed area, and it's a big bag of stuff. It includes prescription drugs, half of which are covered by governments, roughly, and the other half privately. but it looks like the United States, if you like. It's an area where you have both public and private funding, and you have.
When you say public and private funding, I mean, I understand public, but what's private?
Okay, well, first I want to just make sure you understand what the public funding is. The public funding is the 13 provincial and territorial prescription drug plans, which basically provide subsidized drug coverage to residents, either on a means basis or on some other criteria. And then the private is your employment benefit package that you get through work largely will have provision for drug coverage.
Okay.
And the provincial plans fill in the gaps by dealing with basically poor people and retired people. Okay, so so the Canadian system looks very much like that. If for prescription drugs looks like what your whole system looks like.
Yes.
And then you have long-term care and home care. And there, that's, Europeans call that social care. And you have some long-term care homes that are funded by or subsidized by provincial governments. And you have private long-term care. You also have home care, some of which is provided by provincial governments, and some of which you can purchase privately. There are no rules on this, and there are certainly no national rules on this. Okay, so that's the mixed area. And then you have an area which is largely private. Most dental care in Canada is private, it's not public. There's been a little change in that for the poorest Canadians through the federal government recently, but really the majority is still private, and the majority of vision care, other than either one examination or a year or one examination every 2 years, depending on the rules in the province. So that really deals with your public, mixed, and private. So let's just look at that public layer, that slightly less than 50%. In that area, it's a mixed bag. Some provinces prohibit private health insurance. Other provinces discourage it. Some don't deal with it, don't deal with the issue.
In other words, when you say don't deal with it, meaning you could have it.
You could have it. You could have it, but it doesn't emerge because there's not enough of a market. That tends to be in places like Newfoundland and Labrador, where there's not likely ever going to be the kind of market that would propel that. Now, there was a court case in which elective surgeries were an issue. And for cataract surgeries and for hip and knee surgeries, the government of Quebec said, well, if the public system can't deliver this in a timely way, we will allow the private sector to get involved. That was the province that had a prohibition, so they had to deal with an amendment. But that was actually something which you should have known in advance would not actually change anything, because it never created the kind of market that the private health insurers wanted to move in. Just about anybody that would want to buy insurance would have a pre-existing condition, and they wouldn't want to insure. So it wasn't a market, and it never developed as a market. So Quebec certainly does have that exception, but only in that area, and a market never emerged.
So is there any reason that someone who lives in any Canadian province and say they need a hip replacement and they can't wait the year it's going to take to get it where they're living, if they had the money, could they take themselves and that money and cross the border and simply have it done over here somewhere?
They can and they do. And that's where you have some Canadians going to the US, but also going to a few places in Canada where private clinics have emerged. These are clinics that are completely outside Medicare. They basically can only get their income through uh, people who are paying out of pocket from Canada, or if they're Americans playing for a Canadian sports team or a sports team based in Canada and have insurance, they can get it that way. Or another group is workers' compensation, which is a slight carve out of the Canada Health Act. It predates our Medicare system in Canada, and we allow it to keep running. But basically, that's a social insurance system so that if you're injured at work, you basically will have it paid for through your employer.
Yeah, we have it. We have it also. So,
Yeah, that's right. And in fact,
yeah.
workers' comp it grew up just before and during and after the First World War, and it was patterned on what existed in the United States.
So I guess what I'm looking for now going forward, because I read your very interesting paper that you just published on what's necessary going forward in the short term to make some difference. I've done a number of podcasts on the NHS in the UK and their crisis situations. And the one at the 1 year mark, is anything any better? And it just seems to be getting worse, actually, over there.
Mm.
You had you had one interesting comment, which was basically, if I could pull it out, you say that let's do something that we can actually do and not, kind of blue sky stuff that is not going to happen right away. And that seems to me somewhat almost unusual pragmatism. I don't see pragmatism in a lot of what goes on in any government about anything.
Well, the advantage to Canada is this decentralized system. Any provincial government could at any time do just about anything it wants in terms of experimenting and changing how things are delivered. Because it holds the whip hand, particularly when it comes to Medicare services as a single payer. And I don't think Canadian governments use the single payer mechanism enough for good in the sense of innovation. But the good news is that in the past, provinces have been very innovative, and I think they can be in the future, and they could change the way in which, for example, you have access to primary care, the kinds of services that you get, including prevention services that I talked about in that article, as well as managing wait lists more effectively and for elective care, as well as changing the dynamics in terms of emergency department crowding in Canada's largest cities, where that has become a problem,
So
as well.
you don't have the clinics. I mean, that was the inference that I got from you. We do have some of these walk-in clinics or other kinds of clinics that will deal with, in a sense, emergency room issues for poorer people who don't have any regular medical care. But it sounded to me from what you said that you really don't have much of that.
Well, we do have walk-in clinics in the larger centers in the country, for sure. And it all depends on a provincial government whether they're willing to fund walk-in clinics, but most do now in larger centers. They're not out in smaller centers or in rural areas.
And they
Okay.
can't be private, right?
No, they are private in the sense that they're private professional organizations. They contract with the government, but they're under the rules of Medicare.
Okay.
And so they're a part of the public system,
Right.
even though they're private. Okay. It's private delivery, public finance.
Yeah.
And that's why we call it a single payer system. It doesn't imply that the ownership is public. So these do exist, but it doesn't answer the question fully. Moreover, it raises another issue of the lack of continuity of care. And so most provincial governments are working pretty hard to try to figure out ways of increasing the supply of primary care services to meet the demand. And the demand has been growing ever since the beginning of the COVID epidemic. And there was a kind of pent up demand created by the inability to see primary care doctors and other practitioners during COVID. And so now it's really coming up. And you can see this virtually every tax-based system is facing this pressure right now because you have to make the decisions as to what you're going to spend money on through the tax system. And so you're trying to decide, well, what's more of a priority now? Allowing another walk-in clinic or spending the money on trying to get some primary care doctors or nurse practitioners to move into an area and to set up practices there, or setting up your own nurse-based clinic in a rural and remote area, you know? And so there's tough decisions that need to be made on the spending of money.
You talked in the paper about bringing in the nurse practitioners. Um, to our credit, and there's not a whole lot of credit for the U.S. medical system except the wonderful experimental stuff that we've done and the benefits we're getting from that part of it, but that's more scientific. To our credit, we have put the nurse practitioners, and there are 2 degrees here that they can have, taking them higher and higher, out in the rural areas where there aren't, in some cases, any doctors, where hospitals are closing, and let them kind of take over. And then long before COVID and the Zoom conferences, they had the ability to show what they're seeing to a major hospital center and get advice on what to do and all the rest of it. But they've been around and been part of the system for a long time now.
Well, it's existed in another way for decades in Canada. We have a vast geography, and throughout the north, the 3 northern territories and the northern parts of the provinces, we've always had nurse-based clinics called community health centers. And the bulk of primary care has always been provided by registered nurses in those clinics. And that was simply because we always knew that doctors wouldn't move into those areas. They couldn't be enticed to. You could fly one in for a couple of days, maybe once every 3 months, but that would be the best you could do. And so we have had this system operating, and some of the best primary care in Canada is received in those communities because those individuals not only can just walk up to the community health center in the morning at 8:30 if they're not feeling well and get an immediate appointment, but they have wellness clinics in the afternoon where they provide other services that are aimed at prevention and health promotion. And so the quality of care is actually quite high in those communities.
So you have a model in
Primary
a
care.
sense. You have a model to work with in terms of your idea about, and I hope it's not just your idea, but I mean, I hope it percolates through other economies. But the idea of putting these wellness centers in places where they don't exist today, where the emphasis is not on staying healthy, but the emphasis is on fixing illness.
Yes, and I think that that's always been the challenge because the traditional physician-based practice has not integrated enough wellness services, and it's not always the doctor's fault. It's the way the fee-for-service payment system works and the incentives and disincentives offered through that. And we do have, experiments going on in the country. We've had family health teams for years now in Ontario, and those are often led by physicians, But they've integrated a lot more, what I would say, a comprehensive set of services and other kinds of healthcare professionals and are able to offer services, but they have to be paid in a different way to allow for that. So they're often paid in either a capitation way in the size of the population they're serving, uh, or they're paid in a sort of a global fund that allows them to distribute the funds in the way that they deem necessary within the family health team. So there is some experimentation going on. I just wish it was more intense.
Mm.
I wish some provinces would really break the mold and say, well, what we need to do here is something completely different because in this vast geography, there are many different kinds of situations and populations you're dealing with. And so one size does not fit all in terms of the solution.
And I am a pragmatist, and I'm also a journalist, which means I know a little bit about a lot of things, which is dangerous because then you begin to form opinions based on that small amount of knowledge. But as a pragmatist, and as someone who was a marathon runner and who began to take an interest in staying that way, staying healthy as a result of that, it just seems to me a no-brainer that you want to get people to think about preventing illness rather than think about people waiting to treat something that may cost a great deal more to treat or that in the end may not be treatable by the time they get to a doctor. And I just zoomed in on what you said because it's just so eminently practical.
Well, it is. And also in terms of prevention, there's a continuum. You get prevention at an early stage, but you also get later on, you can catch things before they get too bad.
Exactly.
And so the once a year or once every 2 year eye examination has been absolutely critical in catching diabetes in Canada.
Hmm.
And without that, and without it not being included in Medicare, we would have the same statistics in terms of diabetes that you have in the United States, which are disastrous.
Exactly.
And you don't want that. You want to be able to treat diabetes in the early stages so that you are, first of all, allowing a person to have some kind of quality of life for a much longer period. And second of all, you're not costing the system huge amounts of money with that kind of invasive treatment that comes at a later stage of diabetes.
How do you do this? I mean, you make the suggestions in a paper. Who is paying? I mean, I'm not saying this to you and you personally in a sense, but there are a lot of learned people who write papers who say useful things. But in the end, it's a political decision, area to area, province to province, in a sense, in your country anyhow. And it is for us too, state to state.
Yeah.
How do you get the people who have the money who make the decisions to pay attention to something that initially is going to cost money and in the end is going to save a lot of money, as well as a lot of joie de vivre, you might say, for anything else, for people having better lives up to the end of their lives?
Well, here I'm going to be a bit more transparent with both you and your audience, and that is to say that I worked in that position in government. I was the senior public servant in Saskatchewan. I was called the cabinet secretary and deputy minister to the premier, and I did that for a number of years. And I was on the other side of that equation. And I can tell you that if you're trying to influence decision makers, the first thing is you have to be um, very pragmatic and you have to provide whatever advice you're giving in a set of solutions, understanding that there are difficult choices being faced by that government and limited funds.
Mm.
And second of all, you have to pick your timing and your spots. What you're arguing for may not fit the priorities of the government at that time, but at some point it will. And that's when you have to seize the day, if you like, and you have to get in there and make sure that your advice is packaged in a way that it's appealing to the government in question. The second thing is just an ongoing discussion between experts like myself who are out either in academic life or working for foundations, etc., with the decision makers, often the senior public servants, if you like, non-elected officials, as well as occasionally the elected officials, and to be prepared to, in a sense, do whatever is necessary to have the opportunity to have a bit of face time with those individuals. And see if you can exert some influence. But that's all you can do, because you can only, in a sense, influence marginally from the outside. Otherwise, you have to make the decision to either go into elected life or go into a position where you're hired in a senior role to make those decisions.
Isn't it frustrating? I mean, I sit here on the outside, screaming at the TV, half the time, because if something seems so clear and obvious to you, and since it does to me, and I totally agree with you, obviously we're right. But if it seems so clear and obvious to you, and there's a pot of money that every government has, and without raising taxes, that pot of money isn't going to get any bigger. So there's always a push-pull between what can we afford, what can we think about doing some seed money for, what's most important. To try to get healthcare up there with the most important, which I don't think in most governments it really is, because it's reactionary. Well, we need to, if someone comes down with pneumonia, we've got to take care of them. If they've got diabetes, well, we're going to have to pay for the insulin. It's almost automatic because it's the way it's been done. And how do you sit there knowing both sides now, like you do, and deal with it? I mean, aren't you just kind of ready at this point in your life to want to go in with a hammer and say, pay attention?
Well, that doesn't do much good. And I have to say that, right now the timing doesn't feel quite right in my country because we're in a sort of a beginning of a recession caused by fundamental changes in the world trade order, and Canada is one of the biggest proportionately trading nations in the world. And so we're affected disproportionately by the Trump tariffs, etc. And so the government is also running a very sizable deficit, like most advanced industrial countries coming out of COVID. And it's the priority is, in a sense, dealing with this economic potential disaster. And so it's very difficult to focus on healthcare, which always seems like a straight expenditure rather than an investment. And you're looking to make investments basically to reorient yourself to the new economy so that you can survive this. So it is not easy. I've made the argument that, well, this is the time to consider national pharmacare in Canada, because this could be the kind of infrastructure that would prepare us for the next pandemic. And we need to have domestic vaccine making capacity in Canada, and we need to be ensure that we have a secure domestic supply. But we need a different kind of industry to achieve that. It can't be some transplant industry from Europe and the United States. It has to be something that's based on research and development done within Canada. And connect that to other things like the more carefully regulating prescription drug prices. We have the second highest prices in the world. Only the U.S. is higher, and in some areas, and that's why some Americans buy prescription drugs from Canada. But
Tell me
it's
about it.
but it's marginally less. It's not like,
Anything helps.
yeah. The point is we could do that much better, and a national pharmacare program would allow us to do this, and the federal government could take the weight from the provinces, allow them to focus more heavily in their areas by taking primary responsibility for the prescription drug program, because that's the one area and the only area in health that the federal government has a constitutional foothold. It has more of a right to move into that area than even the provinces. So it does have an advantage. And I've been arguing this for some time, but I do think there is a possibility that this is the one area that could change. I leave it up to individual provinces to deal with primary care access and to deal with wait times. They have to deal with that on their own, and that's different, experiments and different management, and moving money around from, let's say, spending freely on walk-in clinics to really building a proper primary care infrastructure.
Is it, I'm just grabbing onto what you mentioned, the waiting list, and I wanted to ask you this early on, but I actually forgot because your other part of the conversation was so interesting. We hear a lot about these scary waiting lists in this country as an example of why we don't want standardized government covered medicine, medical care. Are they really? I mean, the wait lists differ from province to province, and for anything that really matters, is there a wait list that you couldn't wait a little bit longer for, is what I mean. Like a heart issue or a diagnostic.
Well, for urgent care, there's very little waiting in Canada. It's really in the area of elective care that is the issue. And that does vary from province to province. And the issue here is rationing, if it's done through a single tier system, is going to be entirely through this mechanism. So the NHS, which is almost entirely tax funded, there's very little sort of a private parallel tier, is like Canada. And so it has to be managed that way. That's why wait lists are always an issue in tax-based systems. But in the United States, rationing isn't based upon medical necessity. So that's why elective surgery takes a backseat in a tax-based system to urgent care, because it's just not as essential. But the end result is if you're running short of funds, you can push elective care too far, and then a 1 year waiting list ends up becoming a 14 or 15-month waiting list. And then it's just too much, because that elective care is still medically necessary, and that patient is still going through hell waiting for it. So that is a problem, and that needs to be addressed. In the US, if rationing is based simply upon ability to pay and the quality of your private health insurance,
But
then
that's not fair either.
no, that's not fair, but it's also a rationing that you don't see as easily.
Yeah.
The rationing then becomes, well, if you can afford to, or you have the right insurance, you get access. And if you don't even go and see somebody to see what the problem is, because you don't have the money to be able to do it. You don't have the insurance to do it. So when you do go in, it's stage 4, stage 5, it's too late. Or you're into an emergency department in a hospital. An emergency department has to accept all patients, but then you get billed after and you can't pay. And next thing you know, your wages are garnished and you go into medical bankruptcy.
And that
So
has, yeah, that
that's a
happens a
different
lot.
kind of rationing entirely.
Yeah, I mean, the term rationing is not a good one. I mean, I don't mean it's not specific, but I mean, it hasn't got a feel good to it, for anything. But definitely in our country, all kinds of medical care is rationed on basically where you are in the economic system and where you live. Because if you live in much of the South, much of the West, the smaller states, or the states with the least ability to collect high taxes, uh, you're you're covered by Medicaid if you're under the poverty level, but in a lesser way than if you're living in New York State and you're covered by Medicare. Because we're a high tax state, we're a high earning state, we got a lot of money to work with, relatively speaking. There's never enough money,
Yeah.
for anything. But when you start making cuts, as we are now doing in Medicare, because it's half government, U.S. government, and half state government, and you're dealing with the states that really can't step in and help because they don't have the resources to do that. They don't have the tax base. I mean, it really does ratchet down the level of medical care, little that it is that's available to the poorest group of people. And then in the end, they cost the most money because they're the ones who are the sickest, uh, and who need the most attention ultimately because in the United States, you must be treated if you walk into the hospital. And yes, either you get a bill yourself if you're in a certain category, financial category, or we, the general public, get the bill because the cost of our insurance goes up to pay for that. Uh, you know, um, Somebody
That's right.
pays for it, but it isn't the individual because they can't, for the
Well,
most.
and I don't want to underplay the issue in Canada because it is significant, and you see this headlines in virtually every other European system, even in Germany, which has a social health insurance system, complaints about wait times, etc. Um, it is an issue, and now we're getting wait times in emergency department that are far too long and dangerous and have to be dealt with. And we do have to find a solution to this because that is really creating an access issue that is important. And I mean, it's a threat to life at times.
We do now have the walk-in clinics in the big cities. Many of them are 24 hours, uh, but not out in the suburbs. But they do take some of the weight off that emergency room. But I still hear all the time about the triaging with emergency room because poorer people in our country use the emergency room as their doctor. They wait till something is wrong with them and because they don't go to the doctor and then they go to the emergency room.
And I would say the same is true in Canada, and it's probably true in other countries as well. And this is really an issue since COVID. You've got people, with more respiratory problems, and there are more poor people with respiratory problems than middle class or wealthy people. And then the rate of mental health and addictions is exploded.
Yeah.
And those people are using emergency departments all of the time. So we have an epidemic, if you like, certain types of problems that can be directly related to the consequences of the COVID pandemic. And we don't fully understand what's happened, but I can tell you one thing, it's not unique to the US or to
Right,
Canada or
right.
to Britain or to anywhere else. This is a common issue, and we should be working together to try to figure out the source of the problem and how best to address it through our healthcare institutions and providers.
So, on that note, let's kind of wrap this up by looking a little bit at the future. You've got the issues that you just talked about, and we have the medical breakthroughs that are coming fast and furious now, and will come even faster with AI, I think, but that are very costly. Um, you know, I'm looking 10 years, 20 years, 30 years ahead, just really the near future. How are we going to financially manage this in any kind of a system?
Right. Well, when I look at rapid technological change, and I started life as an academic, as an economic historian, but what I see is that generally, uh, in terms of clinical and medical science, there's so much that's sort of at the cutting edge that we're spending more and more in that area, and that's natural. But there are going to be new developments that will begin to bring down those costs. And one of them, I think, is AI, actually.
Mm.
AI is going to actually serve to, over time, bring down some of the costs. So I wouldn't draw a straight line out for 50 years. But by the same token, we can't go wrong by assuming that we're going to be facing this cost pressure, what I would call a growth rate that is much higher than the average for at least the next 20 years. So let's deal with it, right?
Mm, mm.
Let's be practical.
Yep.
And hopefully over time, AI is going to serve us in a way to begin to break down to bring down that rate of growth, but we'll see.
So to be
Uh,
practical, let's go
yeah.
back to what you were saying about the wellness centers and all of that. What what can we ourselves do in a sense? Um, Maybe we don't wait for the medical profession to come up, or even the people who run the governments and the government paid healthcare systems like yours. Maybe we, the people, meaning our elected people, um, are the pressure groups that we have in our country and probably in yours too, that we need to do it for ourselves. Just say we need this to start with so that we can deal with some of these growing costs.
Yeah, that's right. And I think that, we have to accept the fact that our downstream medical costs are going to be growing at a rate far higher than the rate of inflation.
Yeah.
But what we can do is say, okay, then let's really, really, really focus heavily on the upstream. We're going to be spending a lot of money downstream, but let's spend just a little bit more upstream and really try to integrate prevention and health promotion into primary care and ensure that we're doing as much as we can to keep people healthier longer and to catch disease and injury at an earlier stage so that it can be treated in a more effective and less expensive way. And I think that would be money extremely well spent. And it's never going to cost you as much as what you're spending downstream. But if you don't at least take some money and invest in new resources and new ways of providing services, uh, that downstream cost will become unbearable.
And that's kind of the whole idea. We didn't talk about this at all, but you mention it in your paper of also integrating social care or more social care into the system. Because here in the United States, where we have very little social care except what families provide, um, there are older people, they just are in and out of the hospital constantly. For the least little thing can become critical for them because they're right on the edges, a lot of them.
Yeah,
And there isn't really a lot of good home-based system, people who, in a sense, people who make house calls, that could keep them out if they were just dealt with properly, the medications were maintained properly, whatever.
yeah,
We didn't talk much about that, but you've got that in the system too, right? In the ideas.
that's right. And some provinces have done a great job in Canada of providing really effective home care services and are fairly comprehensive and really have served to help people stay at home and stay healthy at home, stay healthier. It doesn't mean that they're going to be able to avoid institutional long-term care forever. At some point, they may have to go into a home, but by that time, we know it'll be necessary, and they will have at least been able to stay at home an extra year or two.
And I think you're talking about buying time in a lot of senses. When you're talking about dealing with what we can deal with now to kind of try to mitigate the expenses, realizing that they're going to grow down the road, but maybe we can slow them down. That is buying us time to figure out, and that would be us, everybody, not just Canada, not just the United States, how we're going to deal with all these greater costs that are bringing us so much benefit.
Yeah, that's right. And we're moving, talking about moving on different fronts, but understanding the connections among them
Right.
very, very carefully. And, when it comes to institutional long-term care, we can't just sit and let that happen the way it is. We had a number of excess deaths in long-term care homes in Ontario and Quebec in Canada. And we know it's because of the poor quality of services and the way in which the homes are being run. And we've got to improve the quality of that. And in particular, our patients are much more ill than they used to be, the average patient. Number one. Number two, over 50% have serious cognitive decline.
Mm.
That wasn't the case a generation ago.
Mm.
And so we need a different kind of approach, and one that really can address the high needs of that cognitively impaired population that are living in homes. And that's going to cost some money, and there's not going to be savings at the end of the day, but we're dealing with a real quality of life issue here that's critical. And not just quality of life for the patients, but quality of life for the people providing the services.
Exactly. Well, we didn't live to be so old a generation ago.
No, that's right. And so,
Nobody planned for that.
you know,
Social Security, Medicare in this country, you took it
yeah.
when you retired at 65 for a couple of years and you died. You know,
Now, the good news is that we're much more capable of working till our 70s, and we don't have to retire as early, and so we can make more contributions. And then in the past, we don't automatically have to sit down at 65 and quit everything. So there's an economic benefit, but there's also the medical consequences of living longer, and we have to address that more effectively.
All right. Well, I thank you very much. I think we covered a lot of territory today. And if you ever want to run for public office and I can vote in Canada, you've got my vote. Thank you so much for taking the time to come on the program.
Okay, thank you.
Dr. Gregory P. Marchildon is Professor Emeritus at the University of Toronto's Institute of Health Policy, Management, and Evaluation, and the founding director of the North American Observatory on Health Systems and Policies. Dr. Marchildon has worked as a lawyer, senior public servant, and consultant for numerous governments and international organizations. In recognition of his impact on both scholarship and public policy in Canada, he was made a member of the Order of Canada. He's written extensively on Canadian history and public policy. His most recent book is Tommy Douglas and the Quest for Medicare in Canada, published by the University of Toronto Press in 2025. I've put a link in the show notes. Now, how does a promising new device or drug get to the human trial stage? And how important is the growing private-public funding and research relationship? In episode 40, we'll be looking at one small medical tech company which has developed a novel device-based therapy for the neurodegenerative disease ALS. and is ready for the first human trials. Episode 40 will drop on the third Tuesday of December, since, as you know, I schedule one new podcast episode a month. If there are any changes, they'll be in my show notes, so please check them now and then. And as always, please subscribe and share. The video version's on YouTube, audio on Apple, and on all the other major platforms, including my host platform, the Podbeam website and app. Show notes and links on my website, stephanieshelton.com/conversations. I'm Stephanie Shelton. Take care of yourself and all those you love, and I'll see you around. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.